See now, this is in the cath lab. We are planning for a percutaneous transhepatic biliary drainage, and there's a brief history saying that the patient had multiple CBD calculi for which she underwent ERCP and stenting, following which after 2 weeks the stent was removed, and subsequently she developed cholangitis, and she's now a little bit sick with all parameters increased, so they wanted us to do a percutaneous drainage. So before going in aggressively for a drainage, we need to see which system is dilated. Is the right, segmental, left, or both systems? So it will help you to plan the procedure much better. So since it is a cholangitis, I would like to use as minimal contrast as possible. See, now you can see on the ultrasound that the biliary duct it's dilated, and you can see some echogenic material within the biliary radicle, which says these are all infectious particles which are there. So as little contrast as possible will be the best. So with this, we'll finish the procedure, and then I'll give you some more tips and tricks on how do we go about doing an entire biliary ductal drainage system. Okay, so let's go to the case, please. See that there's a very white bile coming out, and I'm just going to insert the wire under fluoroscopic guidance. Pretty much. So we just completed a percutaneous biliary duct drainage where we put on one side, the left side, we put an internal external drain, and for the right we kept an external drain. So the procedure is okay. Before going to the procedure, certain key steps that every intervention radiologist should be looking at, and especially it will be very useful for the intervention radiologist in training and for the fellows. Whenever you see obstructive jaundice, we all tend to jump into the procedure, but I would say look into these following points. The level of obstruction. Is it at the hilum or lower down, or is it involving separate ducts? One. Number two, is the bilirubin raise correlating with the amount of intrahepatic biliary ductal dilatation? Because we always tend to forget there could be a parenchymal component of the bilirubin. So in that case, you need to be careful before deciding the procedure. Look into the parameters like PT, INR, and looking for any infective source. So once you've decided that these are the points, and then you've studied the MRCP quite in detail, the person who's going to do the ultrasound, make it mandatory that you need to do the ultrasound, because you can do the punctures and ultrasound guidance or blindly under fluoroscopic guidance. So once you have decided and planned, discuss with your seniors. This is what the plan is. For the left ductal system, ultrasound guided is absolutely necessary and important. The main reason being sometimes the left lobe is atrophied, and instead of taking multiple punctures and creating complications, use an ultrasound to go directly into the left ductal system. For the right, you can do fluoro guided or ultrasound guided, but please make it a caution that when you're doing ultrasound guided procedures, we generally tend to go to the 6 segmental duct, and 30% of the people have the 6 segment duct draining into the left ductal system. That anatomy you need to know prior to the procedure. That means you have to not choose that and choose the left anterior ductal system. But I invariably choose the left anterior ductal system because it is in line with the CBD, and to cross a lesion also it's more easier. And I do both blind as well as ultrasound guided. Now and then, even the most experienced interventionist should try hitting the right system blindly, because the more and more liver transplants are coming into the picture, biliary leaks are common, and when you have to see the ducts are not seen in ultrasound, you need to have blindly. So when you keep yourself training for the right ductal system to keep blindly puncture, it will help you a lot. Once you're suspecting an infection, never inject volumes of contrast. Just inject minimal amount of contrast. Once you see the candlestick appearance, you directly put the wire and try to get to the drainage system. And the last, not the least, is once you have achieved a good drainage system, you need to make sure that the catheter is nicely secured, because you've got locking system and you've got free drainage systems, and depending on that, on the infectious part, you can choose whatever size. Some people use Malicots, some people use internal external drain, some people use external drain, and I prefer usually using an external drain catheter or internal external drain catheter. Usually we just got a pick there. So Malicots, because of quite stiff and sticks on, and I usually attach a colostomy bag rather than a big drainage tube like Euro bag hanging down, because it's very uncomfortable for the patient to turn this side and that side. But the most important key point is taking care of the catheter and the colostomy bag for long sustenance and helping the patient out to make sure that he's free of these excoriations from the skin. It's absolutely important from our side. Once you've decided you put a metallic stent, you want to remove the stent, always recheck on ultrasound and by taking a plain X-ray, making sure the stent is fully opened, and then remove the catheter. If not, then you might have to intervene. Some people prefer doing balloon dilatation of the stent, but nowadays I think there are very few people who like to do balloon dilatation because of the residual stenosis. So these are a few tips I thought I will share during a PTBD circulation. I hope you guys find it useful. All the best. Thanks.